On behalf of the IBCSG and my co-authors, I thank the symposium organizers for this opportunity to present an update of the text and soft trials, randomized comparisons of adjuvant exemestane plus ovarian function suppression versus tamoxifen ovarian suppression versus tamoxifen alone in premenopausal women with hormone receptor-positive early breast cancer. Soft text and PERK were planned as a suite of trials launched in 2003 to answer 3 questions about adjuvant therapy. First, is there benefit from adding ovarian suppression to tamoxifen, in particular for women who remain premenopausal after chemotherapy? Second, when ovarian suppression is given, would premenopausal patients benefit from using the aromatase inhibitor exemestane rather than tamoxifen? The third question asked, among premenopausal women with uncertain benefit from chemotherapy, if maximal endocrine therapy consisting of ovarian suppression plus oral endocrine therapy is planned, is there a benefit while also giving the adjuvant chemotherapy? And unfortunately, PERK closed early, and this question is increasingly discussed 20 years later. First results of soft and text after approximately 5 years median follow-up and then after 8.5 years median follow-up have shown that the addition of ovarian suppression to tamoxifen reduces recurrence and improves overall survival, and further reductions of recurrence are achieved with the use of exemestane versus tamoxifen with ovarian suppression, but without further improvement in survival. We have seen that the magnitude of benefit varies depending on the underlying risk of recurrence, and those patients with lower risk clinical pathologic features have fared very well with adjuvant tamoxifen alone. We're reporting a planned update of soft and text after median follow-up of 12 and 13 years, focused on the later treatment effects. The trials enrolled from 2003 to 2011. Text randomized 2,672 women to either tamoxifen plus ovarian suppression or exemestane plus ovarian suppression for 5 years. Ovarian suppression was achieved initially by GnRH analog triptorelin, with oophorectomy being a subsequent option. These patients were premenopausal and within 12 weeks of definitive surgery, with ovarian suppression planned for all patients from the start of adjuvant therapy, either concurrent with or without chemotherapy. Soft randomized 3,066 women to either tamoxifen alone for 5 years, tamoxifen plus ovarian suppression, or exemestane plus ovarian suppression. Soft enrolled 2 distinct clinical cohorts, patients for whom tamoxifen alone was considered suitable without chemotherapy, and a cohort of women who remained or regained premenopausal status within 8 months of completing chemotherapy. The primary analysis of SOFT focuses on the question of the addition of ovarian suppression to tamoxifen for 5 years. A secondary analysis estimates the benefit of exemestane plus ovarian suppression as compared with tamoxifen alone. In the comparison of exemestane plus ovarian suppression with tamoxifen plus ovarian suppression, combine the 2 trials. Recall the patient cohorts to whom chemotherapy was not given were 45 and 46 years of age on average and had lower risk clinical pathologic features. And note in the text no chemotherapy cohort, 21% of patients had positive lymph nodes. The cohorts who received chemotherapy were younger and had higher risk disease features, and women premenopausal after chemotherapy and soft were 40 years of age on average. Now, after median follow-up of 12 years in the overall soft population, tamoxifen plus ovarian suppression in red showed a modest but persistent relative reduction in distant recurrence versus tamoxifen alone in gray, resulting in an absolute reduction in distant recurrence of 1.4 percentage points at 12 years. The reduction in deaths was more substantial, an absolute reduction of 2.3%. The use of exemestane plus ovarian suppression in blue showed persistent relative reduction in distant recurrence and later reduction in deaths as compared to tamoxifen alone. Below the x-axis, also quantified by hazard ratio estimates in the interval 0 to 5 and greater than 5 years. The resultant absolute reductions at 12 years were 3.0 and 2.6. In the combined soft and text populations, we observed persistent relative reduction in distant recurrence with exemestane ovarian suppression versus tamoxifen ovarian suppression, with absolute reduction in distant recurrence at 12 years of 1.8%. Overall survival now had favored tamoxifen ovarian suppression by 1%. With longer follow-up, this is a reversed pattern, and at 12 years, survival is now 1 percentage point higher with exemestane ovarian suppression. Now, focusing more closely on the clinical cohorts, in the soft cohort who did not receive chemotherapy, distant recurrences are few, but they do continue to be reported with longer follow-up. Over 95% of women are surviving at 12 years since randomization in all 3 treatment groups. Of 52 deaths, 56% occurred after a breast cancer event. There is no evidence of excess non-cancer deaths with exemestane ovarian suppression compared to tamoxifen ovarian suppression or tamoxifen alone with current follow-up, neither in SOFT nor in the text no chemotherapy cohort, which has been added here as dashed lines with the solid lines of SOFT. So in total in these cohorts, 70% of the 79 deaths were after a breast cancer event. In the cohort of patients selected to receive chemo who then remained premenopausal and enrolled into SOFT, a modest but persistent relative reduction in distant recurrence over 12 years median follow-up resulted in a 2.6% absolute reduction in distant recurrence at 12 years with the addition of ovarian suppression to tamoxifen. A relative reduction in death also persists with a more substantial 4.7 percentage point absolute reduction, improving survival from 78.9 to 83.6%. The use of exemestane ovarian suppression, having persistent and later benefits as compared with tamoxifen alone, resulted in absolute reductions at 12 years of 4.5 and 4.0%. And looking together at both soft and text chemotherapy cohorts, with text again in the dashed lines appended to solid lines of soft, in the 2 trials, there remained overall modest or moderate relative reductions in distant recurrence with exemestane ovarian suppression compared to tamoxifen ovarian suppression, which resulted in absolute reductions in distant recurrence at 12 years of 1.9% in soft and 2.4% in the text cohort. The survival was not consistently improved. It was without improvement in soft at 12 years, and with a later emergent improvement in survival of 2.6% at 12 years in text. In these cohorts, 86% of deaths were after a breast cancer event. To better understand the observations for overall survival, recall 12% of the enrolled population had HER2-positive disease, where the results favor tamoxifen ovarian suppression versus exemestane ovarian suppression, shown in the forest plot of 12-year overall survival estimates by subgroup. With enrollment between 2003 and 2011, just over half of these patients received chemotherapy with HER2-targeted therapy. Now, among the predominant subgroup with HER2-negative disease in both trials' chemotherapy cohorts, the absolute improvement in overall survival was 3.3 percentage points at 12 years with exemestane ovarian suppression compared with tamoxifen ovarian suppression. Finally, looking at subgroups of the HER2-negative cancers in this forest plot of 12-year overall survival estimates, and focusing on patients with higher risk features. For those who received neoadjuvant chemotherapy prior to enrollment in SOFT and patients under 35 years of age, the improvements in overall survival with the addition of ovarian suppression to tamoxifen were approximately 10 percentage points, and the improvements were at least 15 percentage points with exemestane ovarian suppression compared to tamoxifen alone. Improvements in survival with exemestane ovarian suppression compared to tamoxifen ovarian suppression were generally on the order of 4 to 6 percentage points at 12 years in higher risk subgroups. To conclude, in this premenopausal hormone receptor-positive population of soft and text after 12 and 13 years median follow-up, distant recurrences and deaths from breast cancer continue to occur, and we plan to continue follow-up for 5 more years. Meaningful relative reductions in distant recurrence and death persist with longer follow-up for use of ovarian suppression in either oral endocrine therapy versus tamoxifen alone. Absolute reductions at 12 years are more clinically meaningful and substantial for those at higher clinical risk on the order of a 10% reduction in death, emphasizing appropriate selection of patients to receive ovarian suppression. Notably, for those patients with low clinical pathologic risk features selected not to receive chemotherapy, the longer follow-up of SOFT continues to support the use of tamoxifen alone for these patients. Reduction in distant recurrence with exemestane ovarian suppression versus tamoxifen ovarian suppression is consistent with postmenopausal women and of greater magnitude for those at higher risk, and showing a later emergent survival improvement with exemestane over tamoxifen with ovarian suppression of 3.3 percentage points for those with HER2-negative disease who received chemotherapy. I thank the 5,738 women who've participated in text and soft and everyone worldwide who supports these trials. Thank you.